it's a real honor to be here for the DocTalks series. I've heard a great deal about this from the Foundation, about the wonderful other speakers that we've had here. Tonight, I hope I can educate the audience about the importance of diagnosing and treating sleep apnea. I have one disclaimer to make, and my disclaimer is that my son Jacob is here in the audience with me, and he's going to keep me straight and narrow on the talk. So if he doesn't like something, he won't be sure to let me know, that's for sure. So let's start off our talk with this. Why would I put up a sign about Star Wars for a sleep apnea talk? Well, we all know who this character is up there, of course, that's Princess Leia. And what does Princess Leia have to do with snoring? Well, it's a sad story, actually, is that Princess Leia was Carrie Fisher, and Carrie Fisher died recently. But the question is, what did she die of? And when the coroner's inquest took place, in fact, what she was told that she was died of was sleep apnea. Sleep apnea that was insufficiently diagnosed and treated. There it is presented as a headline on the Rolling Stone and NBC News and many, many other agencies. And this really brought sleep apnea to the forefront of what's going on. Everyone knows that snoring is bad. People understand that. But the issue of snoring really being associated with a disease called sleep apnea was something people had not heard of before. And so ever since then, this has been a lot of the news and the research and the media. It's an important topic. In fact, it's so important that the Nobel Prize for Medicine was won, this was 2017, for solving the mystery of circadian rhythms in children. One major topic of which is pediatric sleep apnea. So kids can have this disorder as well as adults. And it was that important that our colleagues up in Norway thought they would give the Nobel Prize for this topic. So both from a media perspective and from a science perspective, sleep apnea is up and coming as a major disorder that we can treat. Now, who's this guy? Donald Rumsfeld, right? So back in the day, Donald Rumsfeld had this wonderful quote that I just love it, about the known knowns and the known unknowns and the unknown, I don't know, I get lost. But the point is that what do we know about sleep apnea? Well, I think if we had to have any factual knowledge, it would be this. Here's somebody, it's probably a man, lying on their back, and here they are and they're snoring away. So when someone is snoring, their palate, which is the dangling thing at the back of your throat, is vibrating like crazy, makes the snoring sound. But if it's more than just snoring, you eventually go like this. I'm going to make a loud noise now. And have that happen overnight, over and over. And that breathing cessation, when you stop breathing, is the apnea. Why is that happening? It's happening because of the palate and the tongue being blocked so airflow can't go down, as the diagram shows. That patient's trying to breathe through their mouth with their mouth wide open, but there's no air going into their lungs. And that happens over and over and over again. And so that kind of patient is basically running a marathon in their sleep every single night. Not good for anyone's health. Why is sleep apnea important? So you stop breathing and snore. Who cares? Well, we do care, because untreated sleep apnea is an independent risk factor for high blood pressure. So irrespective of if you smoke or you have a family history of high blood pressure, those things are independent of if you have sleep apnea or not. If you have apnea, if you're snoring like crazy at night and you're stopping breathing and choking and gasping, you've got a high risk of having high blood pressure. Likewise, there's a strong association with depression, type 2 diabetes, dementia, all topics that are very contemporary. Mental health is a huge issue nowadays. It's all over the media. It's a problem at our hospitals. Our patients are suffering from mental health issues, and they are all exacerbated by people who have untreated or undiagnosed sleep apnea. The other risks, of course, are those risks to society. So drivers who have sleep apnea that are not being treated have a 2 to 3 times risk of getting into a car accident. And when you think the fact that about 9% of adult men and about 3 to 4% of adult women have sleep apnea out there, they're on the road on the 401, driving when you're driving. That, to me, fills me with anxiety. Plus, in terms of economic issues, people who have sleep apnea, who are not sleeping well at night, who are choking and gasping at night, they're just not going to be happy, healthy people. They can't work properly, economic productivity goes down, healthcare utilization goes up. So all those reasons are very important. But what's the most important reason to treat sleep apnea? Because it keeps the wife awake at night. So, I mean, sometimes it's the husband, but it's most often the wife. And that's pretty typical of what I see in my clinic, that people come in And they don't say to me, "Doc, I have sleep apnea." And they don't say, "Doc, I have high blood pressure." What we usually have is they say, "Doc, the snoring is keeping me up at night, and he or she are choking and gasping all night long." And I've had couples, unfortunately, yelling at each other in my clinic about how bad the problem is and how bad it may not be. But the truth is that people are aware of this. It can destroy a marriage. It's difficult to be in the same bedroom at night together. All these reasons, personal health issues, social issues, economic and society issues, are reasons to look into sleep apnea. How do we look into sleep apnea? Well, of course, as a physician, we do a history and physical examination, but we also do what's called a sleep study. Why do a sleep study? Well, not everybody who snores has sleep apnea, but a lot of them will. So we can help differentiate plain old snoring, which is an annoying social nuisance, from sleep apnea, which is a true disease. We can decide about how urgent the therapy is. Some patients on a sleep study have the report come out saying you're stopping breathing 5 or 6 times an hour. It's not great, it's not normal, but you can live with that. Some people, however, come back saying you're stopping breathing 60 times an hour, which is basically once a minute. My personal record is a patient who had the sleep index of 120. So they were stopping breathing every 30 seconds. Can you imagine that? Unbelievable. So that kind of thing determines the urgency of therapy. And of course, if we do surgery or if we do use a CPAP machine to treat this, we can evaluate how successful therapy is. So has anybody here had a sleep study? Quite a few. So you may have experienced this kind of thing as a sleep study. You go to the sleep lab and you lie with the things on your chest and along your head and the ECG monitor, blood pressure cuff, your finger probe, an ankle probe, someone's watching you, and there's your sleep study. And we can get all kinds of patterns. Here we have a patient who has obstructive sleep apnea. So we can see on the top bar, their airflow stops. That's the flat line. And as their airflow stops, the effort to breathe, the rib cage and the abdominal movements, they're going. So everything's moving, there's no air going, and the amplitude increases, increases, increases. And most important is this one over here. This is oxygen saturation. And you can see as their airflow stops, the saturation drops. So our body's oxygen level is dropping down. Typically in this room right now, we're probably at 99% saturation. When we sleep, maybe 91, 92. But apneic patients can drop down to the 70s or 60s, so almost half their blood has no oxygen in it. This is very serious business. There's a problem with sleep studies, though, and for those of you who experienced one, I know I've had a sleep study, and I experienced it too, is that it's hard to sleep in a sleep lab, right? I mean, you have these wires all over your body, you've got chest leads, you've got things on your head, it's a hospital bed, and of course St. Joseph's beds are plush mattresses and downfill, of course. LHSC, I can't speak to them. So the sleep lab, though, is difficult to sleep in. And so patients come out of the sleep lab and they say, yeah, I know it's that I have sleep apnea, but I didn't have a good night's sleep. I don't believe the diagnosis. The other thing is that they're very expensive, they're resource intensive, and you get this flood of information that comes out. So that's a bit of a problem because it's too much information. The other problem, though, is this. Doesn't project all that well, unfortunately, but here is a sleep lab that I visited when I was doing a talk in Montreal. It's very beautiful. You had the nice view out the window. It looked kind of like a hotel room. Nice sort of chairs, a nice bed. You had some shampoos and some body soaps, and you kind of want to stay there for a few nights and get a little massage while you're there. It's very nice. So that's a great quality sleep lab. But there are other sleep labs that look like this. How are you going to make a diagnosis of sleep apnea like this? And so there's an inherent quality variation in sleep labs. And so if somebody comes out from this lab with a very severe apnea, we say, so was that an accurate measurement of the way their sleep really is, or the same as this one here where they give the same data? If it's not the same data, how do we decide what to treat? So there was actually an editorial in the Canadian Medical Association Journal, which is our most powerful, high-impact journal. It was called The Writing is on the Wall for Sleep Studies. This was written by the editor-in-chief of the journal. And what did he say? Well, hospital sleep studies are excessive. There's no sound rationale for the various degrees of severity, too much detail, and the truth is that certain kinds of treatment, like sleep apnea, like CPAP, they just kind of work anyways. What's the point of a sleep study? Also, as the prevalence of sleep apnea increases, as there's increased societal awareness of this, there's more demand for sleep studies. The current wait times for our very high-quality LHSC lab, and it is a high-quality lab, I was just joking before, that's actually a great lab, is about 18 months. It's a long time between thinking you have apnea and being diagnosed. Also, what are some other ways to do things? Well, we can do predictive equations, home sleep studies, and hospitals can be reserved for the exception. There is some data to support this. Here is a paper published from Annals of Internal Medicine, a very powerful, high-impact journal, where they randomized various patients to a hospital sleep study or doing a new kind of sleep study, which is a sleep study being done in your own home. And what they found was this. There's a lot of complex data, but I want you to focus on this graph on the bottom left. And what does that graph show? It shows that people who were adhering to their therapy, whether it be surgery or CPAP, were more adherent if they had a sleep study done in their own home, not in the lab. Now, there are all kinds of reasons for that, but the reason the authors quoted was because they believed their diagnosis. They said, well, I had the sleep study in my own bed, my own pillow, nobody's watching me, it wasn't intrusive, it must be the way I really am. So believing your diagnosis is the first step towards getting therapy. We actually published a paper from my group on this, looking at the severity of wait times for sleep testing, showing that the sleep labs, whether they be in the hospital or an independent sleep lab, the wait times are substantially higher than those patients experience when they go for a home sleep study. The Canadian Thoracic Society talked about home sleep studies as well, because they recognize that a home sleep study is a growing part of care. And there are all kinds of criteria that people can use when you want to use them in screening, how they should be applied, but the reality is this is a very large growing part of medical care. Here's a typical home sleep study. A patient has just a couple of chest leads and a thing on their nose that's called Medibite. There's one called Embletta, it looks very similar. And there's one that we do here at St. Joseph's Healthcare, which all it is a little wristwatch device and a thing on your finger. And this here can replace that entire huge rigmarole of doing a sleep study in the hospital. It's pretty amazing. So a brief segue, where did St. Joseph's Healthcare Foundation come in? Well, a couple of years ago, we had a very generous donor who gifted a large amount to our research fund. I did surgery on his uncle, and he was very grateful. And at that time, we were facing just insurmountable waits for clinical care to have a sleep study. And so we thought, let's actually do this. Let's make a home sleep study program. The wait times at that point were 18 months. And unfortunately, they're still 18 months. The foundation approved the capital expense grant to purchase the WatchPat device, which is the wristwatch sleep study device. We developed a process internally for an ambulatory sleep study program. Since September 2016, we've done 207 sleep studies here. It's about 100 a year that we're doing. Now, the LHSC Sleep Lab does way more than that. But still, 100 a year is 100 patients a year who are getting rapid access to care much faster than they could in the hospital sleep studies. The wait times are very short, just a few months. That's basically my own wait because I've got a long wait to see me in the clinic. Study is done the same page the patient comes in. So they see me, we take a clinical history, do a physical. Here's your machine, off you go. Sleep study done that night. No wait times. Results are available the next day because they bring the machine in and we interpret it and off we go. First of its kind in London, and one of the only ambulatory sleep programs in Ontario. We're very proud of that. Significant enhancement to ambulatory patient care at this hospital. Now, it's important to give credit where credit is due. When we think about success, there's the tip of the iceberg. There's all that stuff below there that makes it difficult. I want to thank the people listed here for their vision in helping me realize the importance of an ambulatory sleep program. Okay, so we've talked about sleep studies. We've talked about why sleep apnea is important. Let's move on a little bit here and talk about, so you have sleep apnea. What are we doing now? What do I wish we could do? I want to start off with a disclaimer that CPAP is an excellent therapy. CPAP is a kind of therapy for sleep apnea that when you can use it, it works great and it fixes the problem. We have a similar picture to the one I showed you earlier where the airway was blocked. A CPAP machine you put on your face or on your nose delivers high pressure air through the nose and mouth and into your lungs, and it basically stents open the airway, kind of like a balloon blowing it up. This is what a CPAP machine looks like. Here's the happy guy reading his book. Wife is sleeping, nobody's snoring, everyone's good, life is happy. Right? Of course, it's because it's that easy, sure. There are various kinds of CPAP machines. You can wear ones over the face, over the nose, or over your mouth. Lots of options. The pumps that they used to have sounded like a vacuum cleaner. Nowadays, they're much quieter, and the technology has improved considerably. So CPAP is an excellent therapy. But, there's always a but. And the but is that perspective is important. These are these ads that you may see in the airport for HSBC, and talk about how if you view things with different eyes, you can see the same thing and look in different ways. So speaking as a surgeon, what I would say is that CPAP is no panacea. CPAP is excellent, and when you can use it, it works well. But the problem is this. The academies of medicine that review guidelines for CPAP therapy suggest that if you use the CPAP machine 4 hours a night, a few nights a week, that's enough. But the problem is, we sleep a lot more than that. Right? We sleep about 7 hours a night every night of the week. So if you do the math, this is about half, 50% compliance for about 3/4 of the week. So if you do all the math, multiplication, all that stuff together, you get that acceptable usage is only for less than half of your sleep. In other words, you're being treated for the apnea with CPAP if you use it with maximal compliance for less than half of your sleep time. The other problem is that not everybody likes to use CPAP. So if you can use the CPAP machine, if you can sleep with it over your face, fantastic, because it's a great therapy. But about half of people are unable to use this. And that amount of data has only recently come out in scientific literature as being something people are aware of. CPAP was prescribed very much like medications were prescribed. Here you go, sir, here's your hypertensive medication. You've been treated. No. You've been prescribed. That's not the same thing as being treated. So when a CPAP machine is prescribed and it's gathering dust in your closet, you're not really being treated. You've just been prescribed it. So a lot of patients are unable to adhere to CPAP machines. And there are various reasons why this is the case. The data is pretty consistent about how much people can use and how often they can use it. One of the reasons people can't use CPAP machine: cost, claustrophobia. It's not convenient for travelers. It's not very comfortable. We can see there's a patient here. You can see their nose and their mouth coming out, but you can see the red mark on their face on the CPAP machine. And patients feel kind of like, they say, I feel like Darth Vader. I'm a very Star Wars aficionado. So they say, I feel like I'm Darth Vader with this, with their face. And it's kind of almost as intrusive as the snoring is. So that's a problem. And that's why I have a lot of patients coming to me to asking, what can a surgeon do to help with sleep apnea? So we can do a bunch of things. We can examine your throat while you're sleeping, and we can see what the obstructive area is. We can do some procedures on you, and if we need to, we can do some extreme things. And I'll show you some of that just now. This is my favorite tool. This is called an endoscope. This thing goes inside your nose. It's a tiny camera about the width of a fettuccine noodle. So it's very, very thin. It goes through your nose, into your throat. I look through the front part of it there, and the tip there is a camera that allows me to look with a fiber optic cable inside your throat. We can do it while you're awake or while you're sleeping. So here is a sideways cut of a patient's face. We have the nose, nasal cavity. We have the palate, the tongue. We have the, hope you can see this. Here's the swallowing breathing tube, epiglottis, the tongue, and the palate. And we can put the endoscope just like that through the nose and look down your throat and see what's going on. So let's see what's going on. Now, there's a bit of a disclaimer here that I have a few surgical videos to show you. I'm a surgeon. I can't help myself. But because Jacob is here in the audience, they're very tasteful videos. Nothing bad's going to happen. So you will see some body parts here, but we'll see no faces, only a tiny bit of blood, and I hope that's okay with the audience here. But I think it adds credibility to the talk to have a surgeon show what we're actually doing so you can understand what things look like while you're sleeping. So here's a picture of a sleep endoscopy. So in this sleep endoscopy, a patient is brought to the operating room, and they're given a very gentle sedation. They're not anesthetized. They're just literally snoring away in the operating room. If I shake them and say, hey, Mr. Smith, they would say yes, and they would wake up. But they're just sleeping enough that we can put the scope in through the nose and check out what things look like. So let's do that. Here we have a regular person who has no airway obstruction. So we pass the scope in through their nose. We're looking into their throat. And we can see it looks like we're looking at a long, dark tube. There's the back of the tongue. There's the epiglottis. And through here is where we breathe. So that's how your airway looks when you're just sleeping at night and you don't have sleep apnea. It's like a long, dark tunnel that we can get airflow through. So that's pretty normal. Now, here's a patient. We're going to see what snoring looks like. So imagine in your mind's eye, you've put the camera through the nose, and we're looking at the back of the nose. And this here is the back of your palate, this arch here. So there's no audio on this video, unfortunately, but you can imagine, I'll bet you can guess when the snoring is happening. So here's the patient's breathing normally, and that's snoring. That's loud snoring. I'll show that to you again. That's very, very loud snoring happening. That patient you could hear across the hallway. And what's happening is that the palate's vibrating, and it's making the air column vibrate, which makes a very loud kind of noise. And that's what that person's doing over there. Sometimes we have other kinds of snoring or airway obstruction. Here we're looking much deeper in the throat. If you put your finger on your Adam's apple and say, "ee," you can feel a vibration there. Go ahead and do it. "Ee." So the vibration is your vocal cords. And the vocal cords are seen just behind this structure over here. This is the epiglottis. And so that is the aperture into your trachea and into your lungs. Some patients who have sleep apnea, well, I'll just illustrate for you here. Watch what happens. So this person has very severe sleep apnea. As they're breathing, holy smokes, the whole thing closes off. Can you imagine? That guy is having no air, actually this is a woman, having no airflow here at all. Very, very scary stuff. So that's a ball valving effect of the epiglottis, absolutely, completely closing off there. They're going like this, 100 times a night. Can you imagine breathing like that? That's terrifying. So that's what sleep apnea looks like, especially in the more severe apneics. When we talk about treating sleep apnea, we talk about various levels of surgical therapy that we can do. So we'll start with the nose. This is a picture of the nose cut sideways, and we have the various anatomical structures there. We can do what's called septoplasties or turbinoplasties. Here is a CT scan. This is a CAT scan of a patient's face. We can see their eyes, the brain is on top, and there's this twisted thing right over here, and that is their nasal septum. So this patient, the way they would breathe through their nose is how you would breathe if you put your finger over one of your nostrils. You can feel your nostril on the block side collapsing in all the time. That's their daily breathing. That's their nightly breathing. And this patient will breathe with their mouth wide open because they can't get any airflow through their nose. So we can fix this really easily. In about 10 seconds of video, I'll show you a septoplasty. There's a bit of blood on this video, but it just shows you how quickly we can fix a really annoying problem like this. So here we are. So we're cutting along the septum. That's making a cut along that piece of spur there. And then we're going to just lift up a little bit of tissue so we can expose the bone that's all pushed out of the way. And it's blocking off their airway. This video is real time. It's not been speeded up at all. We then are going to use a little tiny drill. This is made of diamond to burr away that piece of bone so it's just gone completely. And it takes as long as that video shows to do the whole thing. And our final result looks like this. So wide open aperture, as if you've taken your finger off your nose. And that takes about 30 seconds in the operating room to do that. They're fixed right then and there that same day, problem solved. Turbinates are structures that we all have inside of our nose. They kind of look like hot dogs inside the nose. Some people have them to be very small. Others, though, have really big, bulky turbinates that block off the airway. And we can do procedures called a turbinoplasty to open up the airway. It doesn't project as well as I would like to on the video, on the images here, but the patient on the right has a bulky turbinate. The one on the left, you can see a little divot over here. And it's just a few millimeters in, but a few millimeters in the nasal airway goes a long way towards opening up the nose. There are some sort of urban myths about the nose and snoring, though. So a lot of people think that snoring comes from the nose. And it is true that snoring comes out of the nose, but the snoring actually comes from the palate. So the question is, does nasal surgery fix snoring? Does it fix sleep apnea? Does it improve CPAP use? So nasal surgery does not fix snoring or sleep apnea. Let's be upfront about that right now. You can fix the nose all we want. Snoring is not likely going to meaningfully improve. In fact, some people say that snoring may actually be altered after nasal surgery because the nasal resonance is different. But it's important to understand that nasal surgery is mostly designed to facilitate CPAP use. When you have a more open nose, and you couldn't use CPAP beforehand, when you fix the nose and you put the CPAP machine on, all of a sudden, the adherence is a lot better because they don't have that blocked feeling of a hurricane going through their nose. The airflow goes in easier, pressure is turned down, people feel better about that. And the reality is that people want to breathe through their nose. If you Google improved nasal breathing, you get 5 million or so results in a very short period of time. And why is that? It's because people want to breathe through their nose. And if you look at some of the results there are tons of devices that have been invented by very creative people to try and open up the nose. I myself have tried breathe right strips, little things that you stick over your nose to open your nasal airway. They work pretty good. There are internal splints, external splints, lots of things you can do. But why are these things out there? People want to breathe through their nose. It just feels better. So nasal surgery is a great thing to do. Now, that's the nose. Let's go to the mouth now. So tonsillectomy. Who's had their tonsils out? Oh my goodness. Everybody has. So tonsillectomy is a very good procedure, and what's really interesting is that there was a shift away from doing tonsils for a while because it was thought that too many tonsillectomies were being done in kids and there was no reason for it. Simultaneous with that shift, there was a substantial rise in the diagnosis of ADHD in children, attention deficit hyperactivity disorder. Kids who couldn't sit still, they couldn't focus, they couldn't concentrate. A lot of kids are being put on medications. And then this is about in the late 90s, mid 90s. And then there came the realization of the importance of pediatric sleep apnea, whose symptoms precisely mimic that of ADHD. And so what's been happening nowadays is that more and more kids are back to getting tonsillectomies, and the diagnosis of ADHD has dropped. Why? Because they didn't actually have ADHD, they had pediatric sleep apnea. Amazing. So kids are coming off their medications, and with a simple surgery, problem solved. It's not quite so straightforward in adults, unfortunately, but it's straightforward enough that we do offer tonsillectomy to adults who have huge tonsils. So we've all had tonsillectomy here. Ever wondered how it was done? I can show you. So I have a video on tonsillectomy here. It's a short video. There's a bit of blood in the video, but it just shows you how we do tonsillectomy. It's done through the mouth. There's no cutting on the face. There's no scarring anywhere. We go right through the mouth. Tonsils are removed with what's called electrocautery, and then the patient can be fixed very quickly. So here we have a mouth view. This is the right tonsil. Here is the palate, the uvula. Here is the left tonsil. We're using this thing called a tenaculum to grab the tonsil. We're going to pull it this way, and the cautery is going to come in and take the tonsil out. So you pull it over. It's very big, this tonsil. It looks like the size of a golf ball in the mouth. And here's the cautery. Slowly going to cut it out. And I won't show you the whole video. It takes a while to do this. But we're slowly cutting down through the muscle into the tonsil. And the whole thing, bit by bit, is just removed until it comes out. And we can see that as it comes out, there's a huge more amount of space to breathe inside the mouth more than before. Really interesting. You can see it slowly coming out there. The cautery is quite a nice tool. It avoids almost all bleeding. Just move forward a little bit in the video here. So it's just being rolled out. Looks like a little golf ball coming out there, and then that comes out. And that's our tonsillectomy. And as it comes out, you can see how much more room there is to breathe. So, and it takes about 10 minutes to do the whole thing, and then the patient is cured. So fantastic surgery. It's a bit sore for a few days after that, but if it's the right patient, no more sleep apnea. But that doesn't fix snoring, because we saw snoring earlier was the soft palate. So the palate surgery we do is called a palatal flap, and here's what it looks like. We take the mucosa off the front of the palate and then flip it up and suture it to itself. So here's just some still shots of that. Here's the palate being stretched. And I don't have any videos here of this one, but you can see the cautery is just cutting a little bit of the skin of the palate off. And we take that tissue off. There's the defect. And we close it up and suture it to itself. So the end result looks like this, and it heals beautifully. Here we are 6 months after surgery. What we see here is the back of the palate folded up into the mouth, and we can see the back of the throat. If you remember the video of the vibrating thing I showed earlier, that pink triangle was the vibrating thing, but it's now folded to the front. Not there to vibrate anymore. Snoring, finito. So it works really, really well. What about the tongue? We talked about nose, tonsils, palate, tongue. Tongue surgery is hard to do because the tongue is very sensitive. It's a muscular thing when it's sort of cut into. There's lots of nerves to move it around, taste food. So in the past, tongue surgery was very difficult to do. But nowadays we have a great tool called radiofrequency surgery or Ablation surgery. And I'm very proud of St. Joseph's that we're the only hospital anywhere in our region that has this kind of technology. Radiofrequency energy basically dissolves tissue but at a very low temperature. And what that means is that it's way easier to tolerate as a patient. There's way less pain involved and less swelling. So we can do radiofrequency surgery by doing this sort of thing. Put the electrode through the mouth, push it into the tongue, and then we just turn the current on, and it very gently and very slowly with minimal heat dissolves a small amount of tissue. Now, tongue surgery can be a bit bloody, so I don't want to show you any tongue videos here, but what I did was I took a breast of chicken to the operating room. I have no life, believe me, I know this. Okay, I know. What we did though, Jacob's nodding over there, so he agrees. So what we did is we put the radiofrequency energy probe into the breast of chicken and we turned it on. So there it is before, and there it is after. You can see two little tiny white pieces of barbecue chicken right over here. And that's what the radiofrequency energy is doing. So it's just very gently cooking the tissue at a low temperature. As it cooks it, it shrinks it. And when it shrinks, the airway opens up. The beauty of this is that if we look at patients who are the best candidates for sleep surgery, UPPP is a typical acronym for sleep surgery, we see patients who have big tonsils and a big palate have an 80% chance of cure if we do our traditional surgery. If we don't do tongue surgery, the chance of cure is only about 40%. But when you add the tongue surgery onto it, TBRF is tongue-based radiofrequency ablation. The cure rate goes up to about 75%. So those are betting odds. Those are pretty good. What about the back of the tongue? So that was all for the front of the tongue. The back of the tongue can have this sort of tissue on it. Now you guys are anatomical experts now. We know we have the epiglottis, which is that U-shaped thing at the back, right over here. This is the epiglottis. Then we have these blobs, and these blobs here are called lingual tonsils. These are different from the regular tonsils. The tonsils I showed you before are the ones everyone thinks of when you have a tonsil. It's the tonsil. The lingual tonsils, however, are much bigger. Taking these things out is very difficult. Lots of bleeding during surgery. You can have charring. You may have swelling of the throat needing a tracheostomy. No one likes doing that, so enter at your own risk. But again, we have this wonderful coblation tool, and here's the coblation. So you put this through the mouth, like the other one, but now we're going to the very back of the tongue. We use an endoscope, which is a special telescope to look in the mouth as we do it, and the coblator removes the excess tissue. So I'll show you a very brief tongue surgery video. It's nothing grotesque. You will see some liquid on there, but that's not blood, it's just water. So here's the video of the tongue. So we're flying with the endoscope over the tongue here. We can see down into the throat. There's the back of the tongue. And now we're going to bring in the coblator in a second, and we're going to remove all that excess tissue at the back of the tongue. So here it comes now. The coblator comes in, and you can see it's going to melt the tissue away. And what you're seeing coming out is not smoke, it's just steam, and it's just water. There's no bleeding at all, and the whole thing just gets vaporized away. This is the very back of the tongue where there's no real taste fibers there. It's just tissue that helps us swallow. And you can see how deep we can get into the tongue. And as we get deeper into the tongue there, we're opening up the airway, and we're curing the sleep apnea. There's the before, there's the after. You can see the little tiny hole we've made there that opens up the airway. We published our results as well. So tongue surgery works very well, especially with modern technology. It's nowhere near as painful as it used to be. The last surgery is tracheostomy, which is actually making a surgical hole in the throat to breathe through. Now, I've been on staff for 12 years in London doing sleep surgery. I have done only 3 tracheostomies because tracheostomy is hard to deal with. If you have a tracheostomy, you can't swim. It's hard to lie on certain positions. You have to take care of it. It's very visible externally. Only the most severe of patients will get a tracheostomy. People who are literally dying of their sleep apnea. That's rare. But it's nice to see that we can do this. People who have a very high body mass index. So if your body mass index is over 35 or so, traditional surgery is just not going to work because the work of breathing is too high. It overcomes those powerful forces. And so people like this, I would not ordinarily offer surgery to for the throat. I refer them for bariatric surgery, what they call stomach stapling surgery. So to summarize sleep surgery, there's lots of options that are available to people in the upper airway. We can address multiple spots in the airway, and in the right person, not for everybody, these people can be cured of their sleep apnea. Now, I want to be clear, I'm not saying that this is better than CPAP, it's just a different option from CPAP. And so the question I get asked a lot is about how do we compare CPAP versus surgery? CPAP we know is going to work if people use it. Surgery is hard to tolerate, but it can cure people in the right person. There's been all kinds of studies that have been designed to look at this question. And the issue is that they don't quite compare like with like. The patients aren't quite the same. Surgery's not the same thing as CPAP. But it's an interesting discussion. When we talk in medicine about how well something works, we talk about efficacy versus effectiveness. So efficacy is the way something works in the ideal circumstance, for example, the lab. Effectiveness is how it works in real life, such as your home. So if we look at the concept of compliance, how it relates to effectiveness, if we think about CPAP, CPAP works 100%. If you use it, 100% you're going to be cured. But its compliance is about 50%. So that's how kind of a graph of CPAP would look. If we look at everybody who ever comes for surgery, the compliance is 100%. If you have surgery, you've had surgery. But the efficacy of surgery, if you take everybody in the world having sleep surgery, it's probably about 50%. The rectangles look similar though. So they may actually have similar effectiveness. There have been a few studies that have compared CPAP versus surgery. So there was one study that compared 100 people to 100 people, and here's the graph that it showed. I don't want to show too much data because graphs can be a little bit tiring, especially late at night. But basically, here's the survival of people who had severe apnea who were not treated. They didn't do well. By about 8 years out, or about 50% mortality. So people were not doing well. If you had CPAP or surgery, it's the graph up here, they did pretty much the same. So in other words, CPAP versus surgery in this patient population were very equivalent. Now, if we look at another study, the guy named Ed Weaver, he works out of Seattle, a very famous sleep surgeon, studied 20,000 patients in the VA system out there. 20,000 is a huge number. These are both patients' populations being treated for apnea. And let's be honest, both groups did pretty well at 6 years out, about 90% survival. But if you remember our acronym was uvulopaltal, which is our surgery that we do, the surgical group actually did a bit better than the CPAP group. Not a lot better, but enough better that it made a difference for the study. And why was that? It's because when you had your surgery, you're treated. The CPAP only worked if you were using it. And so the main issue with CPAP, of course, is the compliance. So if we look at our graph again, here is the CPAP graph. If we pick the right patients for surgery, so people who have large tonsils, the big palate, modifiable tongue, not overly overweight, and we operate on them, we know that our chance of success is about 80%. So here's what that graph looks like. So in the right patient population, we can really do a great job with the surgeries that we can do right now. For my last 5 minutes of my talk here, I want to dream a little bit though. I want to tell you about the what if, okay? So all the surgery we talked about so far is surgery that's relatively invasive. We're cutting things, we're removing things. It's a little bit sore, time off of work, there are some risks of bleeding. What if we could do a procedure that could get the same results but remove a lot of those risks? Wouldn't that be amazing? Well, we actually can. That's called hypoglossal nerve stimulation. The hypoglossal nerve is the nerve that moves the tongue like this, in and out. Very important nerve. I showed you earlier the epiglottis flopping backwards. When your tongue moves forward a little bit even, just a bit, the epiglottis comes forward too, no more apnea. So an amazing company in the United States developed this thing called an implanted pulse generator. And what they do is they put a little thing like a pacemaker in your chest. They have one lead, a little tiny probe that goes into your chest muscles and senses when you breathe. And a second lead goes up through your neck and into the hypoglossal nerve. And it wraps around the nerve. And this is very intelligent technology. So it senses when you're going like that, it triggers the impulse for your tongue to go like this. Come out just a little bit. Not stick out the whole way like a snake. Just a little bit. Here's how that looks. So we have here a dissection of the patient on the cartoon version. There's the nerve. And then the implant itself wraps around the nerve right around over here. And here's just a photo of that being wrapped around the nerve there. But what does it look like? And the inside is more important, is this. So there is the epiglottis with it off, almost blocking the airway. Here it is with it on, totally turned on. And the amazing thing is that this is all we do is a little cut here, a little cut there. Nothing in the mouth. So there's no invasiveness beyond those two little cuts. No removing tongue tissue, tonsils, palate. This can achieve the same result. It's amazing technology. If you look at a sleep study, here's this huge graph, but all I want to show you here is that this is the patient with severe sleep apnea, and you can see those oxygen saturations dropping, dropping, dropping. Then you go dropping, dropping, dropping over and over again. And then turn the implanted stimulator on, stays up. No more desaturations. So this thing really works. In fact, it works so well that it was the headline article in New England Journal of Medicine about a year or two ago. The front page article, because it's a transformative technology. It was amazing. The results they got showed that in patients who had this device put in at baseline, their apnea-hypopnea index, which is a measure of the number of times per hour your breathing is stopping, their oxygen saturation index, how much oxygen is dropping, at baseline, very severe. At month 12, you can see it drops down to almost nothing. But the cool part was, you turn the device back off, and the apnea comes right back again. So it's clearly the device that's doing this amazing work. Patient compliance, in terms of how much they use the device, is almost 100%. So you can't beat that. No one's going to be perfect, but it's very, very good. So maybe you're thinking, great, where do I get this? Do you want to buy an airline ticket? Right. So where's Canada? Why not Canada? Well, it's expensive. So this thing costs about $15,000 US. With the exchange rate nowadays, it's going to be pretty bad, unfortunately. It's not yet Health Canada approved. unfortunately. I've been working with the company to try and do, my professional goal is to be the first surgeon in Canada to do this technology. And it's not a hard surgery because we do that kind of work in the neck all the time. But the company has basically said that our market's small here in Canada. We have 1/10 the USA population. They just don't want to expend the effort to come. Unfortunately, Health Canada considers it to be an experimental device, and so we're having difficulty getting patients covered in the USA. Canadians are being left behind. And even more so because only until recently was sleep apnea even recognized as something important. So much so that the OHIP fee schedule, the way they pay physicians, put this, the uvuloplatoplasty, this is actually in the way they adjudicate procedures as being paid, is only insured if somebody cannot tolerate CPAP. So they didn't want to give even the option to do this surgery under OHIP. So OHIP didn't consider sleep apnea to be important. Now, as we've shown in our data tonight, it is important and the prevalence is huge. So we're petitioning the government just now to make these changes, and I hope that they will. But this hypoglossal nerve stimulator, to me, is the way of the future. And I'm hopeful that in the next 1 to 2 years we can bring it to Canada. That would be an amazing enhancement to patient care. So, in conclusion, sometimes you look at all the data out there and it looks like a big mess. This is a collection of forks, knives, and spoons in an ark in a museum that I saw once in the USA. And it looks like a big mess. When you shed the light of science on some data, you can get an amazing shadow come out, right? And so that's the shadow, that's where the light comes out and makes sense out of crazy, complex data. And we're just now starting to do the fact that light of data dispels the mess of myth. So there was a lot of old myths about sleep apnea, and modern data that I've showed you tonight can actually dispel that in the light of science. The other thing is that some things are hard to believe actually exist, right? This is a cookbook that I saw called The Pulmonary Clot Witch with Flatlining Mayo. It's 4 fried chicken sandwiches mixed with bacon and pepper jack cheese. Yummy. Coronary heart attack, but so good going down. But the reality is that some new findings are hard to accept, right? And we have nowadays modern evidence that shows the power of surgery and the way we can improve patients' lives with doing the right procedure for our patients. So here's some old sleep apnea treatment axioms. All sleep studies are done in a lab because it's the best way to do it. CPAP should be the first-line therapy, and surgical treatment is second choice. And that was the way it was, I would say, 20 or 30 years ago. But here, home sleep studies are more and more replacing lab studies. And I'm so proud of St. Joseph's Foundation that they were able to understand this and partner with me and our generous donation community to make this a reality for our patient enhancement of care. In some cases, surgery can nowadays be the first choice because we can cure people. And surgery and CPAP both have a complementary role to treat sleep apnea. With that, I will stop. Thank you very much for your time.